evening. Welcome to the Radio 1 Live as we discuss in matters of the heart, conditions and lifestyle factors that impact heart health, being sponsored by the University of Maryland Medical Center Midtown campus. I am Kelson. I know you're looking forward to Shay. She's way more prettier than me, but you guys are stuck with me for the evening. She's way more prettier than me. Good morning, Dr. Not good morning, Sam. You still on the morning show this evening. Good evening, Dr. Lalonde and Dr. Haque. How are y'all doing?
Doing well. I think working a little echo there. I'm Dr. Lalonde. I'll start out after when Dr. Haque is getting back. I'm a primary care doc, so do some outpatient internal medicine over at the University of Maryland Midtown campus. But work pretty closely with the cardiology department, of which Dr. Haque is a part of.
Dr. Haque, how are you?
Hello. Yeah, hi, I'm Reyaz Haque. I'm one of the cardiologists at University of Maryland Medical Center, Midtown campus. And thanks for the invitation to participate tonight.
Of course. And if you have a question as we're doing this conversation, make sure you leave your comments in the chat. We'll try to get to the doctors. They'll do a better job answering the question because me, I have no idea. They're the professionals. They're the skilled ones, okay? But like I said, leave your comments in the comments section. Special thank you to University of Maryland Medical Center Midtown campus. I think it's kind of cool that we're doing this Matters of the Heart live in February, which is, well, I know it's the love month about the heart. So let's get right into it. Is there like an age risk where one should pay attention to, the heart more so than other ages? Like, should it be when you're 30 plus, 18 plus?
I can take that. Any age really, depending on the risk factors as such. But I think that after the age of 40, everyone should be aware of risk factors for heart disease and getting regular checkups that include, blood pressure, getting lab work done like cholesterol checks, etc. And we can talk about that. If you have a strong family history, may have to do it earlier when much younger.
I've been seeing a lot in the news where a lot of athletes have been having heart issues and dying, on the field. What from your experience, what do you think the cause could be?
With athletes, it could be many different things, but it could be something congenital. They're quite young. It could be related to hypertension, sometimes dehydration, etc. But at that level, I'm sure the athletes are undergo regular checks, their blood pressures, etc. And some may even undergo some more invasive testing like echocardiograms and all to know whether they have any underlying heart conditions before competing at that level.
Mm-hmm. I hear like a lot of kids I know also when they were born, they have heart murmurs. Is that a condition that increases your risk to have heart issues as you get older, or you can like grow out of those?
Good question. I think most of those are addressed when they are young, but they are followed regularly throughout their life then. And there are so many different conditions, but very well treated nowadays by our pediatric cardiology colleagues, and then they continue to follow those patients.
Okay. Now, I know in the African American community, I will say high blood pressure is running rampant and hypertension, and it's been referred to as a silent killer. Why has it been described as the silent killer, and what are some risk factors or things we should look out for that?
Yeah, I can take that one. So generally, right, they call this the silent killer, right, is the moniker kind of tossed to it. Because sometimes if you're not getting to those kind of extreme levels of hypertension, you might not really have any particular symptoms. Whereas we do know that, right, even in those milder hypertensive forms, so kind of not to the extreme, but not normal, you still do increase your risk for things like cardiovascular disease over a long period of time. So the signs and symptoms of things like, very elevated blood pressure can be things like vision changes, like blurriness of the vision, headaches and things of that nature. And, it varies person to person. That tends to be when you get to much higher blood pressure levels, but they call it the silent killer because it's kind of that middle ground. you might be completely asymptomatic. And again, if you're not kind of undergoing screening, seeing people like your primary care doctor, cardiologist, or other healthcare professionals, and having that blood pressure checked, you may go years and never know.
Mm-hmm. Is there a certain population that's more at risk to have high blood pressure than others? Dr. Haque or Dr. Lalonde?
Yes, I believe they are. Not quite exactly sure why, but yes, the African American population more prone to high blood pressure, and going from there, I serve, at Midtown Hospital, and we see a lot of hypertension in our patients. And hypertension, like you said, not only is the silent killer, but it's the root cause of most problems that I see here. Not only is hypertension a major risk factor for coronary artery disease, which is blockages in the arteries of the heart, but also for heart failure, kidney failure, stroke, etc.
Mm-hmm.
So we have to aggressively treat it, and yes, it is more common in the African American population, but it is treatable as well, and perhaps preventable. And that's the main focus of our clinic now, because it is preventable, and regular exercise, weight loss with regular exercise goes a long way. And some dietary modifications which not only reduce your salt but also reduce weight, etc. So I believe a treatable condition, but it'll take a generation of aggressive management of these risk factors to see some outcomes.
So in other words, we should no longer use salt at all, or maybe some pink Himalayan salt and things of that nature.
I'm all for good eating and enjoying what you eat, but I think in perhaps portion control and more exercise, that would certainly help.
Yeah, I'm born and raised Louisiana, so I know the importance of some good food and some good flavor. But
seasoning is important.
Yeah, right. No, and it's just being mindful, right? So, not overdoing. If it's salty, you probably put too much salt, right? Things like lemon pepper, maybe a little bit of seasonal, things of that nature, right?
Yeah. So there's stuff like Himalayan salt, sea salt, and then iodized salt. So I guess the pink Himalayan salt is probably the better option to use if you even have heart issues.
Dr. Lalonde?
Yeah, I mean, probably nothing particularly better than the other. It's more of not overdoing the salt, right? So it's just being again mindful about how much you're putting in. Obviously, it does flavor things. It's why we use it, right? But just being mindful, not overdoing it. Again, if you're eating it and it's starting to taste salty, you've probably oversalted.
Yeah. So Dr. Lalonde, are there any lifestyle factors or related medical conditions that can increase the chance of high blood pressure and heart disease?
Yeah, so some of the things that Dr. Haque was bringing up earlier in terms of what we consider lifestyle modifications and things we can do to improve our cardiovascular risk factors. So obviously obesity being an increased risk in terms of cardiovascular health. Diet as well. We're talking salt earlier, but there is, and we have to talk about what's called the DASH diet, right, or the dietary approaches to stop hypertension. Fairly well studied on dietary changes. I mean, that's increasing things like fruits, vegetables, low-fat dairy, trying to avoid processed sugars, sweets, doing healthier snacks like things like nuts. Not only to try to improve our cholesterol, but also trying to improve that diet to improve weight management. But also, things that we do on a day-to-day basis that are addressed in hopefully all of the healthcare spheres you see, whether it's cardiology, primary care. But talking about modifications like smoking, talking about modifications like alcohol use, right? We know other factors that can be modifiable that can decrease your cardiovascular risk long term.
Okay. And one thing when you go to a doctor's office, like a CVS or Walgreens, even the grocery store, they always have the little cuff for you to get your blood pressure checked. How often should you get your blood pressure checked?
So it depends on your risk factors, right? So if you're someone that has high blood pressure and is being treated for high blood pressure, ideally, right, you should be able to be outfitted with a blood pressure cuff at home. My preference is always a blood pressure cuff that goes over the forearm and not one that goes over the wrist, though obviously having one is better than none at all.
Yeah.
And then making sure that we're checking our blood pressure accurately, right? So making sure our arm is at heart level, resting on something like a table or the chair side, that our feet are nice and flat on the floor, ideally not having a real hectic space around us, right? Being able to do kind of nice slow breaths and kind of running that cuff twice to get a nice average. If you're a completely healthy person, right, the national recommendations would be at least seeing your doctor yearly to have your blood pressure assessed. But again, if you have risk factors, if you have family factors, if you have known difficult to control blood pressure, then maybe more frequently. We do send patients home with things like blood pressure logs to check as much as once a day to again bring that information back to myself or Dr. Haque or other healthcare professionals.
And then if you do have that situation where you got to take one home, you guys ask people to write down what they ate and what they were doing to help kind of monitor like the pressure and the cholesterol and everything.
Yeah. So, or Dr. Haque, you want to take that one?
Yeah, I think in my practice, I stress compliance with medicines. That's sometimes an issue that we, need to make sure we take our medicines on time, keep our diet, mostly constant. Sometimes after a weekend of eating well, sometimes things change. But again, I think it comes to, yes, diet, but exercise is important. I think often neglected by all of us, So that helps. And I just think that it's all preventable. Bad diet or a poor diet and lack of exercise leads to increased weight leads to hypertension, diabetes, perhaps high cholesterol, and those are all risk factors for heart disease. And then increasing weight has other consequences, back pains, joint pains, knee pains, and that is a vicious circle that in kind of leads to more sedentary lifestyle because patients cannot or are unable to exercise because of all those aches and pains. So that leads to more weight gain. Then another thing that happens with weight gain and obesity is obstructive sleep apnea. When you're snoring a lot and kind of stop breathing at night, that leads to more fatigue. But not only that, it leads to higher blood pressures and rhythm disturbances. Of course, high blood pressure can then lead to kidney problems. Kidney problems can lead to heart failure problems. So it's all linked. And it all starts, I think, with eating right and exercising. And so it's all kind of linked. Monitoring your blood pressure, like you said, once a year is fine. In patients with hypertension, more frequently. And yes, I believe in having a cuff at home. Sometimes they're not as accurate as we like them to be, and I ask my to bring in their instrument, whatever they're using at home, into the clinic so we can compare our blood pressure machine with theirs and see if they correlate.
Okay. If you're just tuning in, talking about Matters of the Heart for Dr. Haque and Dr. Lalonde. Special thanks to the University of Maryland Medical Center Midtown campus. If you got a question like Kelly has, make sure you put it in the comments section. It says, what number should you aim for when checking or having your blood pressure checked? Can you explain the difference in the numbers?
Excellent question. Can I take that? So
Of course.
120 over 80 is the ideal blood pressure, and especially in diabetics, it shouldn't be on that. Why I say great question is that I take care of many patients who think that 150 or 160 is okay for them. But no, it isn't. So, the definition is anything over 120 over 80 millimeters of mercury. And certainly if it's the top number is going over 140, that's a matter of concern.
Okay. So that's just for everybody 120 over 80. I know some people say, well, I'm tall or I'm big boned, so it's different for me. Well, I'm African American, so it's different. Everyone should be 120 over 80.
Generally, yeah. And because after 140, you're really risk damaging your end organs, including kidney damage, etc. And I tell patients, and if it gets to 150, 160 range, you're really increasing your risk of stroke and heart
Mm.
failure appreciably.
Dr. Haque or Dr. Lalonde, what's the difference between the top number and the bottom number? Like, what's the definitions, or what do they actually measure?
So that the top number is, the pressure with which the left ventricle squeezes the blood out of the heart. And that is more important right now. Generally, for patients, won't want to get into too much detail, but that is the pressure that we want to reduce. Reducing blood pressure also reduces the workload on the heart and prevents heart failure, because an acute elevation or even a chronically long-term elevation in blood pressures can put a lot of strain on the main pumping chamber of the heart, which is the left ventricle, and ultimately lead to not only problems with the pumping function of the heart, but heart failure. So, like I said, we aim for 120 over 80.
Mm-hmm.
And anything higher, we should control with low salt diet, exercise, and medications.
I know one thing that's very important to everyone, that what are some, I guess, some techniques if someone is having a heart attack or think they're having a heart attack, what should they look out for, and how can they, how should they respond to that?
Yeah, like blood pressure, sometimes people don't know there are classic symptoms of heart attack, which are like heaviness in the chest pain, shortness of breath, um, usually brought on with activity. So, again, there are many silent heart attacks as well.
Mm-hmm.
Sometimes in the elderly, they don't present with those classic symptoms of chest discomfort, shortness of breath, etc. Sometimes in elderly, especially ladies, women present differently. So we just have to have a level of suspicion, and I encourage them to seek medical attention. Certainly, if you have these symptoms with exertion, that means whenever you walk or exert yourself and uh, the heart is not getting enough blood through the blood vessels that may be blocked, it's something of concern, and they should seek medical attention.
Okay. Now, is this myth, or is it true, the tingling in the left arm when, as a sign of a heart attack?
Mainly chest discomfort. Again, yeah, if some of the other symptoms are there, but tingling alone may not be. But again, we take things together. For example, if there's somebody getting really short of breath with just going up steps at home and having some chest discomfort and then some numbness in the arm, I would take it more seriously. But if that tingling is more associated with pain in the neck or comes on, but at other times, but yet they're fairly active without any of the other symptoms, I wouldn't worry about it too much. So we kind of evaluate all the symptoms together, and then their blood pressure, vital signs, EKGs, etc. when we evaluate them. So encourage, if anyone is concerned, contact your primary care physician or us, and anytime, or of course urgent, if the patient think that they need more urgent care, then they need to ED or some urgent care center.
Interesting, because when you think of heart attack, I know for me at least, you think of something dramatic, grab your heart and you fall out. I was not aware that the silent heart attacks, and that I guess people don't know that they're having them.
Often happens. Patients are not aware. It could be more subtle. It could be an episode of heartburn that they ignored. They thought it was related to food, and then subsequently did damage some of the heart muscle and have had shortness of breath ever since, or not felt well. So this, yeah, we see all kinds of presentation. And again, when patients are concerned enough, they should seek medical attention. Coming back, it's all about treating the risk factors, right? The hypertension, the diabetes, not smoking, keeping your cholesterol under control, and all of those help a lot. So exercise, diet, not smoking, help a lot.
Doc, I feel like you're looking straight at me saying exercise and watch my portions.
You haven't seen the rest of me.
Right, this is a no judgment zone. We're here to help you get your heart right as we discuss matters of the heart. So if you got a question for Dr. Lalonde or Dr. Haque, make sure you keep your comments coming in the comments section. And once again, thank you to the University of Maryland Medical Center Midtown campus. And I guess one of the recurring things we're talking about tonight is blood pressure, getting your pressure checked, exercising. You guys have some pressure checks, I guess, at your center, at the Community Health Education Center, located on the lower level of the outpatient tower. Tell me about that, please.
Yeah, no, that we do. So we have the availability down on that basement level. It's also kind of a utilized space for things like classes. Right. So we're kind of talking about other risk factors for cardiovascular health. One of those being things like blood sugars, right? The risk of things like prediabetes, diabetes. There is a pre-diabetic prevention program that's kind of run primarily out of that lower level of the Midtown Health Center. When we talk about things like healthier eating habits, right? We're talking about things like access to healthy foods. We have been able to have at least, I think, monthly now, generally on Fridays outside of our health center, having kind of fresh discounted produce, whether it be fruits, vegetables, other things that kind of help drive that healthier eating aspect.
And how is heart disease diagnosed and treated?
So I'll take that. So, we have our community health education center, but if there are any symptoms, contact primary care physicians, and Dr. Lalonde and his team are also available in our outpatient tower. If there are symptoms of heart disease, as we discussed earlier, we're cardiologists on the 9th floor of our Midtown Center campus tower, outpatient tower. We do, all the studies there that are available, EKGs, to see whether there are any electrical abnormalities, echocardiograms to see how well the heart's pumping, etc. Usually, we can do stress tests. We give heart monitors to detect rhythm problems. We can do CT scans of the heart. And of course, right then, if we feel that the patient is unwell enough or unstable enough, then we just walk them across the street to the emergency department and get more treatment there. That might also end up with an admission. Now, if they're there, again, we have stress tests available, all manner of imaging studies for the heart to diagnose pretty much any heart condition. Many heart conditions require further evaluation, like you mentioned, heart attack, that requires a heart catheterization, which is when we inject dye into the arteries of the heart to see where the blockage is, the blockage that's causing the problem. So we do that at our downtown campus. We're basically one hospital at two different campuses. So we, via ambulances, we transfer patients for more care at the downtown campus. And that could be, angiograms, putting stents in, or various other procedures to open up blocked arteries. We can fix valves. You may have heard of patients getting now aortic valves replaced, through via a catheter rather than open heart surgery. Pacemakers, defibrillators, and all manner, there are many other procedures in patients with atrial fibrillation for irregular heart rhythm, they're at a higher risk of stroke, so they're on blood thinners. But if they're not tolerated, there are other devices that we can use in the heart to prevent blood clots. We can fix valves, as I said. And then, of course, there's the surgery, bypass surgery, valve surgery, more therapies for advanced heart failure. They're all available. And you may have heard from the news that we have heart transplants too. So
Mhm.
our primary care through to general cardiology to more interventional cardiology, heart surgery to heart transplants, we have it all there in I believe, a really seamless way. The patient just enters the system and we can provide all manners. And it's not only the heart, it's not an isolated organ as such. We work with our pulmonologists who are on the same floor as us. Like I said, a lot of our patients have sleep apnea. We work together. There's a lot of heart and lung disease. We work very closely with endocrinology, which is in the same building, taking care of our diabetic patients. We have kidney doctors, nephrologists, because a lot of our patients have kidney issues. So we have all other specialties, and they do their own testing as well, right there at the tower at Midtown or in the hospital.
Mhm.
And so we give care across different specialties to take care of our patients' problems. And not only do we have that community health education center, we have a very good smoking cessation clinic as well. And that has done really well. We have dietitians, nutritionists, and physical therapy there. So we offer a lot more towards prevention and also taking care of our patients who already have heart disease, heart and lung disease.
See, tonight we're talking about the matters of the heart, conditions and lifestyle factors that impact heart health. Got another question in from Ms. Chancellor saying, is it possible for someone who has a pacemaker to not have to rely on one, or is this reversible?
Good question. Pacemakers are put in because at some point the heart rate was too slow for some reason. And usually that's the electrical system of the heart, as opposed to the plumbing system where there's blockage in the arteries. So pacemakers are put in to prevent the heart rate from slowing down below a certain heart rate. It might be 50 or 60, whatever. So many of the patients who may not need their heart pacing all the time, it's only there when the heart rate drops. And it's usually implanted in those patients who really have a higher risk of slowing down to a point that they may drop their blood pressure, etc.
Okay.
But
And
that's a question it would be an individual one to ask with their cardiologist who is taking care of their pacemaker.
so it's different for every person.
Yeah.
Exactly.
Again, if you got a question for Dr. Lalonde or Dr. Haque as we talk about matters of the heart, make sure you put your questions in the comment section. We'll make sure we get them answered. Again, special thank you to University of Maryland Medical Center Midtown campus. Does heart disease, as we're talking about it, does it differ from men to women? And if so, how does it?
So, I mean, in terms of how it differs, I mean, you could talk about prevalence differences. Generally in the premenopausal female population, not as much as men. Once women kind of enter a postmenopausal kind of later in life as well, with men later in life, prevalence kind of starts to average out. Obviously, risk factors change. That's going to change person to person, right? So, do you have obesity? Or are you a smoker? Do you have heavy alcohol use? Do you have a strong family history, right? Those things might change things, but that would be the general prevalence when we're looking at the kind of the sex differences.
Okay. And of course, I think we said earlier, sometimes that age can be a factor when it comes to heart disease.
Yeah, it's fairly linear in terms of prevalence or how frequently we see it increasing with age. Like Dr. Hawk was saying at the beginning of the program, kind of often looking at that 40 years old, though again, it can happen at various ages.
Because we see like children, they're so young, have heart issues, and then you have some, older adults that have heart issues as well. So just like you said, it just depends on that particular person. Well, as they said, make sure you're visiting your PCP, getting your blood pressure checked consistently. And if your family has a history of it, you definitely want to do it more often than, the annual when you go see your doctor.
True. When it comes to women, Dr. Lalonde described that well, but often they do not present with heart disease with the classic symptoms. So we have to have a higher kind of suspicion in those patients and not ignore some of the patients. In my practice, they tend to be older and less active. So you can't. Another thing that helps in patients who are active, because a lot of the heart disease symptoms manifest when you're active, right? Because if you can't run up steps or go jogging, or patients who are more sedentary can't tell that they're deteriorating over time. Whereas active people would say, hey, I used to walk 10 blocks and now at 5 blocks I feel short of breath. So that serves as a very important kind of symptom that we look for, a decrease in exercise tolerance. In elderly women, I find that sometimes they're more subtle symptoms, and we have to be more careful with the history we take. And some say that we miss some disease in elderly women, or are late in diagnosing heart conditions. So we just have to be more careful. And of course, in my practice, again, I see a lot of elderly women with higher blood pressures, and we need to get them to go.
Got another question coming in. I've heard of people who worked out have a lot having heart attacks. What would make persons such as this more susceptible to heart attacks? Is it genetically related?
So, the risk factors for heart attacks, which are caused by blockages in the arteries of the heart, are diabetes, smoking. Especially if diabetics smoke, they significantly increase the risk of heart attacks, high blood pressure, and family history. The best thing is to control that. So if you have a family history or diabetes, we must stop smoking, treat hypertension, treat high cholesterol, and that's the best way to to decrease your risk of a heart attack. Of course, that includes dietary restrictions, as we've discussed. That also includes exercise. So those two keep coming into the picture. So, in order to reduce your risk of a heart attack, smoking cessation, diabetes control, blood pressure control, cholesterol control. And there's nothing much we can do about our family history. But if we get our cholesterol low enough, I don't think that should matter. That won't play into the bigger picture.
Okay, April's checking in saying, what is your thought on frequent coffee or caffeine consumption and blood pressure?
So, I mean, in the short term, right after drinking a cup of coffee, right, there may be a slight increase in blood pressure, right? Could be a slight increase in things like heart rate with the caffeine consumption there in the coffee. I mean, if you're drinking coffee frequent enough or having enough where you're feeling things like palpitations or you feel like it's raising your blood pressure, it may be, time to take a step back and look at the amount of caffeine consumption that you're taking in, right? But a good cup of coffee in the morning, right, does start a lot of people's days. But it's being aware, right, that there can be a slight increase in blood pressure after drinking a cup of coffee. In terms of that effect lasting persistently throughout the rest of the day and keeping the blood pressure high throughout the rest of the day, very low concern on that standpoint.
Okay. So if someone is having issues with their heart, do they need a referral to see a heart specialist?
So that's dependent on insurance, right? So there are some insurances that do require you see your primary care provider and then obtain a referral through that to see a cardiologist. Obviously, right, and changes on what office you might be going to see. Our office does have the capability, right, to do some of the screening in terms of that initial EKG, right? We even can order those next level tests if needed, if we have high enough concern, right? We're on the 10th floor. Dr. Haque and the cardiology team are right there on the 9th floor, right about as easy as can be to kind of have that connection between teams. But no, again, it's I know so many of the answers are, it varies, but it really depends on insurance. Knowing what sort of insurance you have. Do you have an insurance that requires referrals to see specialists, or are you one that could see one without a referral?
But in my opinion, as a cardiologist, I would add that it's always good to see your primary care physician, right?
Mm-hmm.
So that they know what's happening. They're the ones taking care of the patient. And it's always good practice for the health of that individual patient to always go by their primary care physician with symptoms so they can coordinate the care. That translates into much better care.
If you're just tuning in, we're talking about matters of the heart, conditions and lifestyle factors that impact heart health. Got Dr. Lalonde and Dr. Haque here to answer your questions. So if you do have a question, make sure you put your questions in the comment section. We'll make sure we get them answered as best as their ability. Not from me, but from the doctors. They're the professionals here. So if someone's just tuning in, what are some of the common, I guess, the most common heart conditions that you see, Dr. Haque?
So the most common heart conditions that I see are heart failure and coronary artery disease. And well, now that there's also some rhythm problems like atrial fibrillation, which are fairly common. Again, it comes to the risk factors for coronary artery disease that we talked about: diabetes, hypertension, high cholesterol, smoking. So again, preventable. For heart failure, in my practice at Midtown campus, it's always high blood pressure, some alcohol use, some drug use, and high blood pressure, of course, increases the risk of kidney problems. Many patients come with kidney failure, and that exacerbates their heart failure symptoms. And of course, atrial fibrillation is a rhythm where the top chamber of the heart beats fast and irregularly. And that too is related to hypertension most of the time in my practice. So again, all of these, the most common heart problems I see are really preventable by, again, addressing the high blood pressure and other risk factors. But once they have those, like I said, in the outpatient setting, in the hospital, not only Midtown campus or downtown, we have, the capability to address all manner of heart problems and other like lung disease and diabetes, etc. as well. And but again, at the tower, with Dr. Lalonde's help, what we are trying to do is to keep our patients, our local population, from going that far down that line. We want to prevent all of this.
So if someone does have a heart issue, and let's say, I'm trying to think, I just lost my train of thought when the question came in right there. But is it reversible? Like if you're going down the road and having these heart issues, because I know sometimes they say, "Coach, and work out and eat better." Is the heart condition reversible, or at this point, if it gets bad, is just treating what you have?
Good question. Yeah, again, an individual thing. A lot of patients who have heart failure due to high blood pressure, it's reversible if they take their medicines appropriately, completely. Many patients with high blood pressure, with exercise, etc., alone, I have seen. I had such a patient today. So blood pressure normalized and generally feeling a lot better. And it's not from just blood pressure control because they're exercising, etc. I think there's generally a feeling of, feeling better. So a lot of them are reversible. Of course, once you have coronary artery disease, we can do things like fix the arteries with stents or even do bypass surgery, but those are fixes for something that's already advanced, right? And then cases, our aim is to prevent those problems from coming back again. So when we put a stent in one of the arteries of the heart, our goal is that they never come back with a heart attack. And hopefully, again, boils down to addressing those same old risk factors.
The prevention is key. Yeah.
Right.
Yeah. Got a question from Dave. Dave says sometimes heart issues can mimic other problems like indigestion. How do you know the difference?
Right. It's again, you're routing back to something we were talking about earlier, right? Always having that high degree of clinical suspicion, right? So never forgetting that this is a possible, what we call differential diagnosis, right? So a possible cause of what could be going on, but obviously taking that whole picture into effect, right? So is it I'm eating, and if I have spicy foods or caffeine or chocolate, I get some central chest burning, or right when I lie down and I'm eating dinner late at night, now I'm having some burning and an acidic taste in my mouth. Is going to be different to, like Dr. Haque was saying earlier, right? Maybe having some of that almost indigestion sort of feeling, but it's maybe brought on by exertional components, right? Maybe I'm going to exercise and I'm having kind of this reflux sort of feeling, right? So it's taking that whole clinical picture into account when we're trying to parse out what could be going on.
Is there any risk between energy drinks and increased heart attack risk, or is that just an urban legend? That's from Dallas Lights checking in.
I think it's probably not a heart attack per se, but I've seen a lot of rhythm problems. So, we use the term heart attack liberally, in the sense, for us cardiologists at least, it means a blockage in an artery that causes damage to the heart muscle. But many others, it's an event, so a heart attack of any sort perhaps. But with energy drinks, I've seen a lot of rhythm problems of the heart causing issues, and they can even cause patients to pass out, and it can have serious consequences. So again, an individual thing. Some people are more prone to it than others. They don't mix well with drugs, I think, in my experience from taking care of patients. So I don't know if that answers the question. Dr. Lalonde, do you have anything to add to that?
No, an individual approach, right? I would definitely say if you're someone who's maybe for the first time in a while picked up an energy drink or something that you've been drinking for a while, the energy drinks, and you realize that you feel that heart fluttering or the heart, feeling maybe abnormal, or you just don't feel well when you drink an energy drink. Again, maybe taking that step back, trying to figure out causation, but coming to see your primary care doctor. All right, something we can talk about. We can do things like an EKG. We can try to make sure that we're not missing something.
Dallas Lights also asks, how do you get your heart back into rhythm if it gets out of rhythm? And do they have to stop your heart? How does that work?
So when you have a rhythm problem, you usually feel this fluttering in your chest. It's usually associated with a lot of anxiety, shortness of breath, even chest discomfort at times. In fact, those patients can feel that numbness that we talked about earlier. So again, it's best in that case to present to the emergency department and be evaluated. That can be dangerous. And we have several medicines that can, in an urgent situation, slow down the heart rate, or as we say, break that rhythm problem and restore normal heart rhythm. Sometimes when that doesn't work and patients are very ill, dropping their blood pressure or have passed out, then we do deliver what we call cardioversions, electric shocks, to bring them back into rhythm. Some of the patients, may need further treatment. And in these days, like I said, when we admit such patients to our Midtown campus, then we can offer what we call electrophysiology studies, which are done by our cardiologists who are experts in electrophysiology, or the electrical system of the heart. They can perform what are called ablations to get rid of some rhythm disturbances permanently. Some people need pacemakers, some people need defibrillators. So it again depends on what kind of a rhythm the patient has.
If we were to see someone having a heart attack, what would you tell like a bystander or a person that's near to do to help them, as they're going through this moment?
All right, so obviously if there's strong enough suspicion of a heart attack, right? If you have any baby aspirin on you, right, you could give that person some aspirin. And right, if they're pulseless, right? If you're concerned about the rhythm, if they're not answering, right? Talking about things like our basic, right, CPR, our BLS sort of candidacy, right? So it's a good thing that they're teaching in jobs, they're teaching in school fairs, right? The more people out there that know CPR, if necessary, right, the better. It can definitely save lives. Also, in the more public places, we have things like defibrillators. Right. Again, if you're concerned, it should be someone ideally trained in that matter. But across the board, the most important thing, right, is if you can't be CPR trained, get CPR trained. It's an important skill to have.
And I was going to add that was one of the things I wanted to talk about today was that I think everyone should be taught ACLS. I've been talking to, whether all high school students should know. So if somebody wants to help, and not only help, one day you may save a life if you know BLS. So they are available through American Heart Association. I would really like our community health education center to start some program where community members could learn to do this and be certified to do it, because you will save a life doing it.
Dr. Haque, can you break it down again? You said ACLS with BL. Can you break it down for us?
The BLS is what we the basic life support. So that's like the CPR, the pumping on the chest and giving some breaths, etc. And I think we should do a better job in training our community in this.
If you're just tuning in, we're talking about matters of the heart, conditions and lifestyle factors that impact heart health. Special thank you to the University of Maryland Medical Center Midtown campus. Special thank you to Dr. Haque, Dr. Lalonde. I messed up. See, I told you I messed it up. Dr. Lalonde. I called myself though.
Almost got through.
Right. So you got a question for one of the doctors about if you're having heart issues or just want to know about getting your blood pressure checked, make sure you definitely ask your question now, or you can even log into that website to get more information about heart health. And as we got about another 10 more minutes, let's kind of run back through everything we kind of discussed. What are some prevention methods to prevent heart disease or things to prevent heart disease?
Right. So again, getting established into the medical field, right? So seeing your primary care doctor, right? Being able to do those at least yearly checkup or screening, where we're looking for things like your blood pressure, and like we've been kind of talking about this entire time, prevention, right? So trying to beat to the point of avoiding that heart attack, avoiding the heart failure, avoiding the rhythm problem by being able to address our risk factors of things like getting our blood pressure under control, talking about smoking cessation and what can we do to help you to quit smoking, what can we do to help you change your diet versus is it picking that one vice that you have, right? Is it that soda that you have with lunch every day, right? Talking about things like getting our exercise better under control, or being able to do more exercise, right? So they say WHO would say anywhere from 150 to 300 minutes of moderate exercise each week, right? Trying to get that heart rate 50 to 60% above your baseline, and then getting that 50 minutes to 100 minutes of vigorous exercise each week, right? What are these lifestyle changes that we can implement early so that we can prevent the issues later on?
Do you recommend just cardio or cardio plus, I guess, muscle building or other vigorous exercises to help with heart health?
So it's really whatever you're comfortable with to get that heart rate up. Obviously, right, having a good degree of cardiac heart, right, being able to get that heart rate up with things like, even if it's just going for walks with friends at lunch around your building, right, taking the dog out in the evening, if you have the ability of having any sort of home exercise, or if you live next to a Y, right, all these things just to get out. I always say never go from 0 to 100, right? If you're someone that hasn't worked out or isn't working out recently, you don't need to go out and do an Ironman, right? It's slowly building. It's setting reasonable goals for yourself, right? Saying, maybe one afternoon a week, I'm going to start with doing this, knowing that I can achieve that goal, right? And starting there instead of setting something that might be unreasonable for you, and then getting down on yourself if you're not achieving that. So in terms of aerobic and cardio versus muscle building, right? They both have a place. I tend to say maybe leaning a little bit more onto the aerobic and cardio, and then adding on some some muscle building, but just even getting to the gym and doing that exercise and getting your heart rate up in general is going to be good for your health.
Mm-hmm. Now, is there a certain exercise that's better than other ones, like swimming or bicycling or maybe just walking, that you guys notice that helps more to prevent heart disease?
I'll take that in the sense that I think the more important thing is to increase exercise and whatever that may be. So today, whilst Dr. Lalonde was saying this, I completely agree. I was told one lady, she goes up her one flight of steps once a day and gets short of breath. But I say, you got to do it twice now, build it up. Every week, do a little bit more than you did the last week. And that could be walking down the hallway in your apartment building, could be a flight of steps at home. You don't necessarily need a membership to the gym to for activity in, go out. I realize that it's cold. Sometimes it's not safe in the evenings to go out. But, we can do things to one elderly lady I saw last week, just told her to just walk around the dining table and count how many times she does it, and every few days she should increase that. So as long as they're exercising more, and again, if you are exercising more, meaning you're able to increase your exercise, that means you're doing good, and you don't really need any more testing from us as such. But it's only when you're declining that, look, I used to be able to walk, like I said earlier, 10 blocks, but now I can only walk 6 or 7, get tired, get short of breath. Then we need to take a look and figure out what's happening.
Mm-hmm. I know we're sitting here talking, I'm still just in disbelief because for years, and now I've realized there's an urban myth about if you feel a tingling in your left arm going up and down, that means you're about to have a heart attack. But you guys, debunked that myth as a sign for like a heart attack or a heart episode.
Well, I won't completely ignore it, but it has to come together with some other symptoms as well. And again, if there is nothing else to explain it, we're happy to evaluate and take a look. So I don't want to ignore it. But usually with, chest pains, shortness of breath, etc. And and also for heart problems, the duration matters. For example, you can't have, earlier we talked about indigestion, but you can't have that for 3 or 4 days continuously, because if it was the heart, something worse would have happened already. So again, it's, did you eat something? Did you eat something spicy or something else that doesn't? So we do take a full history, and that's very important. I still rely on my history more than a lot of the testing that we offer.
Dr. Haque, how does your team collaborate with the Midtown Health Center primary care team with the heart surgeons and cardiologists on UMMC's downtown campus?
So, like I said, we are all located. It really works so well. It couldn't be better. It couldn't be more perfect. So, like I said, the primary care physicians are there, but there are also a lot of primary care physicians in the building next door to us, and they refer to us as well. And then we have like heart and pulmonary and GI on one floor. We have endocrinology. We have all the other specialties there. If something is, we do a lot of testing there. If something is needed more urgently, we have an excellent emergency department, and then the whole hospital to admit those patients. Like I said, there are many tests that we do at Midtown. Others are done at downtown, and all manner of heart, lung, whatever issues, we can take care of. And then, of course, we have CT surgery if anyone needs surgical stuff, if you need pacemakers, defibrillators. It's all available, and it's pretty seamless, They transfer patients ourselves. They don't have to. It's like one hospital over 2 campuses, and one kind of center with an outpatient tower, Midtown Hospital, the downtown hospital. It's all linked seamlessly, and we all know each other. We work with each other, and And again, it's not only a heart problem. They usually have lung problems, they usually kidney problems, diabetes issues. So we all have to work together
Mm-hmm.
care of the patients.
And one thing I've been hearing a lot often that for dental, if you don't take care of your teeth, that's going to lead to issues with your heart and, issues in your body. So how it's all connected together.
True. Yeah, that an infection on the teeth can go into the bloodstream, and as the blood flows through the heart, the bacteria that are flowing in the blood can affect the heart valves, and that can be a
Mm-hmm.
serious problem.
Yeah.
Extremely serious.
So how can patients make an appointment with the Midtown Health Center primary care?
Yeah, so for primary care, right? If we go onto our website, right, you can see it down below. I've always want to do that. No, so yeah, they've got the website down below, the phone number there down below. It'll get you down to central scheduling. You can talk through there. For most of our primary care providers at the Midtown campus, if we do have availabilities, you can also see our availabilities online and kind of go try to set up an appointment through My Portfolio or kind of our central app-based scheduling as well. And then a different number for our clinic specifically is that same 410, but 856-3660 is our primary care number. You can talk to our front desk at any time and try to get an appointment through that way. Again, we have multiple providers in our clinic. Multiple of us are still taking new patients. So just give us a call if you need us.
Yeah. And as you said, ummidtown.org, or down below, as Dr. Lalonde said. And wrapping things up, what are both of you please share important heart health tips?
Again, prevention, right? So not waiting until your 40s, 50s, 60s, and now there's an issue and we're playing catch up and we're doing procedures. Obviously, right, the medical community will always be there for you if you need it. But our goal in particular is primary care and cardiology as well, because we're working together, is that prevention, right? So me doing my job should ideally be we're dealing with changes early, we're making lifestyle changes early to where we're not having to have issues down the line. We're trying to prevent that first occurrence happening.
And yeah, I had to explain it to a patient today that it's we work to improve our patient's health, whatever condition we first see them in, but it's a team approach, right? We work with the patients, so they need to do their bit. Smoking cessation is big, drug use, alcohol abuse, excessive drinking, exercise and diet that we talked about, then taking the medications as prescribed. Unfortunately, sometimes there is a bit of confusion on what the patients are taking. They themselves get confused. It gets complicated. If they are admitted at a certain place, they may go to some other hospital and then come back to us, and the medication list is the word we use is reconciled. Their switches in medications, and that causes a lot of confusion with the patients, and that's where we as doctors should do better. It's always good to the patients should take their medicines with them to the doctor so we know exactly what they're taking. I think that is very important. And so it's a partnership, and some who are sicker, we see them more frequently. Like if you have really high blood pressure, then we need to see you every couple of weeks until we got it controlled. Same for certain other problems. So it's a partnership, and we're there for our community, and we work with each other. I think we've got a really good system going with this outpatient tower, and we're all enjoying working together and serving our patients. So hopefully in 10 or 15 years, we would notice that the incidence of heart attacks, heart failure, maybe dialysis due to kidney failure is coming down. And that'll all be because we treated hypertension better 10 years earlier or 20 years earlier.
So if you've been listening, the key word is prevention. Work out more, go see your doctor, take care of that heart, you can do that by calling 410-856-3660 or visit ummidtown.org/primary care. Dr. Haque, Dr. Lalonde, thank you so much.
Oh, of course.
Pleasure being here. Thank you.
Thank you, Kelson. Appreciate it. It's been a pleasure.
Of course. Have a good night.